We have one more talk before the coffee break, so if people can stick it out through one more talk and one more set of questions, that'd be great. Now we're going to talk about the Ruane Prize. The Ruane Prize has there were so many good people. They gave it to the single prize to two people. Dr. John Constantino is who I'll introduce first. He comes to us from Atlanta, Georgia, where he has two kinds of positions. One is as a professor of psychiatry and pediatrics and in a Blake Chair for Children's Behavioral and Mental Health as an academic-like position. And then he has another kind of a position, I don't know how he does both together, but maybe he'll tell us, as a systems chief of behavioral and mental health at the Children's Healthcare of Atlanta, like the Children's Health Hospital. And his aim, I'm just going to read you how he puts his aim in his material. He says that he has an aim to develop a national model for sustainable delivery of the full continuum of evidence-based mental health care of children. So he not only wants to develop what the best treatment is, like many of us do, he wants to make sure that it gets publicly implemented. There's other things that Dr. Constantino has done, and most of the other things I'll mention he did when he was at WashU to kind of fit into with the theme of today. He was interested in social development in children and understood that we had to have a tool. So he developed the social responsiveness scale. He developed it, he tweaked it, he perfected it, and then he gave it out to the world. So that now youth who need social treatment can actually be identified. He is interested in developmental disabilities in children, particularly in child social development. So with his scale, he can develop the social responsiveness scale. He can develop quantitative features of autism. He can validate that and disseminate that and all that he's all done with the social responsiveness scale. And then he was one of the first people actually to look at the genetic structure of autism. We all think of autism as a very pervasive disorder that has a very strong and modulated genetic basis. But that is a rather new concept, perhaps, of the last decade, and maybe you can tell us more about that. But there was a time when autism was thought of as being very rare and a prominent genetic disorder. Now, Dr. Constantino will tell us about new horizons for child psychiatry from research on individual differences in early social development.
Great. Carol, thank you for that introduction, for that very kind introduction. And this is in many ways a celebration of the support of young investigators. And I want to really recognize and thank the Behavioral and Brain Research Foundation, Brain Behavioral Research Foundation, for its extraordinary support of the launching of careers of young people. Nolan's mention of Anish Mitra, who is his student, was my student at Washington University before that. I'm very proud to say that. And so I'm a child psychiatrist. You've been treated so far in this symposium to Discovery Frontiers for higher impact intervention for psychotic disorders and mood disorders. And now we're going to talk about social developmental disorders of childhood. And I'm a child psychiatrist. So this is a picture of a pair of identical twins from Missouri. You can identify them a little bit from Missouri with their crew cuts and flannel shirts, but these guys are identical twins. And one of the things that we learned about autism very early on as one of the profound disruptions of social development in childhood, we learned from studies of twins and families. Now, I'm going to cover today a little bit about autism, a little bit about another very profound, high-impact public health disruption of social behavior, which is antisocial development, that is the precursors in youth to pathways to delinquency and crime. And I want to begin, though, with the story of how we studied autism. And these little guys were one of many, millions of twins and siblings and half-siblings and family members from around the world have been studied with respect to autism. And the conclusion from all of that work in terms of understanding how autism works in families is that in the case of identical twins, if you are the identical twin of somebody with autism reared together, over 90% of the time you are also going to have autism. In the case for non-identical twins or siblings reared together, same exposures, same vaccinations, same pesticides, same fertilizers, same environmental exposures, but you just cut the genetic similarity in half. And the trait concordance for autism plummets to 20%, from 90% to 20%. Similar for half-siblings, plummets from 20% to 5%. And this is the pattern of a polygenically determined condition, just like many of the higher genetically influenced conditions of psychiatric conditions of human beings, including schizophrenia. And so one of the things that we wanted to do from the very beginning was to understand what's familial about autism. What runs in families and why does it run in families? Now, a lot of people have learned about genetics of autism from very important and spectacular findings of single gene causes of autistic syndromes. But by and large, the vast majority of those single gene syndromes are not familial. They don't run in families. They arise in the germline in an individual child and do not account for what is transmitted in families about autism in general. And so about 15% of all of autism is accountable by these kind of single gene germline genetic conditions. But 85% of autism, it's estimated through studies of millions of twins and family members, that it's inherited. And so how would we begin to understand inheritance of autism, of a polygenic condition that's running in families and that may show little signs of the condition among relatives? And so it began with essentially developing a scale. Carol mentioned this. This was back in 2000, the social responsiveness scale. And we developed that scale in order to measure autism in a way that hadn't really been done before, which was instead of you have autism or you don't, let's just consider all gradations of the syndrome. Similar to what Nicole described for psychotic syndromes, so thinking about it differently as a gradation of symptomatology. And if you just count the traits and symptoms once we developed a scale, the second graph shows this distribution in all humanity. This is one of many population studies of autistic traits and symptoms. The x-axis is symptom count, so higher on the right, lower on the left. The y-axis is the proportion of the population that's affected at that level. And that plot is a bell curve. It shows that in all humanity, not just with people with autism, but in all humanity, that burden is continuously distributed, just like height, weight, blood pressure, and other quantitative traits. And one of the most interesting things that we found very early, and this was just counting symptoms using we're not talking about high technology here. We're talking about counting traits and symptoms. And one of the things that we found by deploying this scale in populations of twins and families was that it was as heritable as autism itself. And it subsequently was learned that the actual polygenic factors that determine the condition of autism is determining that bell curve in the entire human population. It's about the social development of all of us. And so we subsequently looked at the differences in those distributions between individuals who were related to a person with a psychiatric condition that wasn't autism versus, that's the control on the left, and those individuals who had autism. The scale was able to distinguish those by about 3 standard deviations. And if you look at their first-degree relatives, their siblings, their brothers in this case, you can see a shift in the entire distribution of all of the brothers, unaffected children, not that they had autism. These are the unaffected siblings of children with autism, but their trait distribution is shifted to the right. This is one of our early studies, and this has been replicated over and over and over again, that you can use these trait counts to trace the aggregation of these traits in families that are segregating polygenic risk for the condition. And so when we looked at the life course using these same methods, again, just counting symptoms, what we were seeing was that across that entire spectrum, wherever you were at time 1, on the upper right-hand is a scatter plot over years of time of baseline measurements on the x-axis and years of follow-up on the y-axis, wherever you landed in that distribution at time 1, years later, you were in the same place, all the way into adulthood. And these plots summarize that in 10-year follow-up studies of what was going on with these distributions of traits. So the question then became, how do we trace what we're measuring with these simple trait counts back into not only the genetic structure of autism, but actually the biology of autism? And for that, we needed to get in front of autism and to think about how could we relate these trait measurements into things that we had a handle on in the early development of autism. And there existed, developed by a tremendous group of researchers at Emory University, formerly at Yale University, a method for identifying a recurrence predictor of autism in families. Okay, so when autism is familial, what predicts it in a family or in the younger, a child born into a family where they are at risk for autism, what predicts their development of autism is a pattern of erosion in visual disengagement, eye contact, that begins to occur in the 2nd month of life of that baby, progresses, and you can't diagnose autism at 4 months, 6 months, 8 months, not until 18 months generally is when one can make typically a solid diagnosis of an autistic syndrome. But these changes in eye tracking were visible from the time of 2 months and in decline. And so this gave us a window to think about, well, is this an opportunity to not only to identify early autistic syndromes, but actually to change the course of what's happening, that even before the syndrome develops, that these tracers are available. And so it was shown that after this particular, in 2013, it was shown that those erosions in eye contact were actually predicting the development of autism. And so we asked a very simple question. We wanted to copy the Emory laboratory, do the same experiment, but do it in the whole population, in a general population sample of twins. And what you see on the lower plots is on the right, let's start with identical twins. So identical twins, and we used 18-month-old identical twins, and the x-axis is the proportion of the time that they spend in their visual experience oriented to eyes, looking at people's eyes. And the way that that's done experimentally, in a biomarker study, is through eye tracking technology. And I'll show that in a second. But essentially, I want to tell you the result first, is that if twin 1, as an identical twin, in the general population, spend 60% of their time looking at social scenes and that they're focused on the eye, that is exactly how much time twin 2 spends, looking at eyes. But you can see from this plot, this is a general population plot, that twins are all over the place. Sometimes they're 80% of the time on eyes when they're looking at social scenes and videos. Sometimes they're at 10% and so forth. So, but if you're an identical twin, whatever your time and proportion of time spent on eyes, that's what your co-twin is doing, exactly the same. Now on the left, look at the dizygotic pairs. So that is a plot that shows that they're all over the place. And so remember, with dizygotic twins, you're cutting the genetic similarity in half. So the point being, a strong indication that this biomarker that was predicting autism in families affected has this kind of exquisite genetic influence, again, in all humanity, in the entire human population. But it's even more than that. So one of the things that we did in the eye tracking experiments is that if you're going to do this experiment, you got to show the twins the same movie. And you eye track them and you ask how much time are they spending on eyes. Well, just for the fun of it, we said, well, what if they're watching different movies? Well, the results didn't change. Even if they were watching completely different scenes, okay, then if you're an identical twin, that's how much time you're going to spend looking at the eyes in those scenes. And then we did another analysis. And I'm going to show the next analysis. So I want you to look in the upper left-hand side of the screen. And these are a pair of non-identical twins. Their tracings are summarized in this video where you're watching, as they were watching the same video, what does identical twin 1 do, or non-identical twin 1 do, and what does non-identical twin 2 do. So you're going to see that. Oops. Maybe we can get hang on one sec. Let's back up. Maybe run this one. Okay, so twin 1 and twin 2 are approaching this common experience in a little bit of a different way. You know, they have a different pathway of how do they use their eyes to size up when this person is talking to them and telling them a story. Now, let's look at what happens with a pair of identical twins, watching the same person telling them a story. Here's the plots. So we have thousands of hours of twin data, and it's as if those are glued together. These are two separate human beings, and we're following the course of their moment-to-moment eye movements in a tens of millisecond time scale, and they're locked on the basis of their genetic structure. Okay? And so this was one of the first demonstrations of something that Sandra Scar said at the very beginning, in the very beginning of my career, in her presidential address to the Society for Research in Child Development, that individual differences may be a function of children using their differential genetic makeup to reconstruct the environment and what they experience in the environment in different ways for different kinds of outcomes. This was one of the first experimental evidences, some of the first experimental evidence for that. Okay, well, on this plot, you can see that there are a bunch of, on both the MZ and the DZ scatter plots, there's a lot of low eye lookers, okay? And almost all children with autism are in that low eye looker category, but not all eye lookers end up having autism. And that told us something, that even though this was an important biomarker, predictor, linked to genetic factors, linked to polygenic risk, there might be some other players. And in fact, we found them. So in the colored panel on the right-hand side, I'm just going to summarize that amazingly, what we learned when we asked what was predicting autism, not only did these social visual disengagement phenotypes predict autism, but you could ask about the parents' autistic trait background, measure the autistic trait burden in the parents. You could actually ask interesting questions about the motor development of a baby or their hyperactivity, their activity level, and their ADHD type traits, because there's a lot of polygenic overlap between ADHD and autism, as a clue for why did we even look for those. And the amazing thing about those four things is that they are completely genetically independent from one another. Now, we have a handle on four different polygenically determined liabilities that come before autism, that predict autism recurrence, and are a next generation of targets for the condition, for preventing or ameliorating the severity of the condition. So autism, instead of being one quantitative distribution, is hiding 4 quantitative distributions at least, we think. And this is part of the next, sort of generation in research. The left-hand side, it's fuzzy to see, but it's a diagram that was published by Arthur Guyton about blood pressure. And blood pressure, similarly, is a quantitative trait. It's a single number, but underneath it is vascular resistance, volume, electrolyte balance, kidney function. And he showed how all of those, particular components are in dynamic interface with one another. And it's possible that this condition and some of our psychiatric conditions actually work that way. And this has resulted, this eye tracking technology has actually resulted in FDA-approved devices now to pick up and ascertain these in young children. It's bringing the diagnostic time from hours of time of a clinician to 7 minutes or 8 minutes on a device. This is a really important advance, and I don't take credit for this. This has been forwarded by others who have used these data to validate the notion that we can start syndicating diagnosis early this way. So this is an exciting thing on the horizon. Okay, so we've been talking all morning about discoveries, about better treatments, about higher impact intervention, about new discoveries. But I want to turn the talk for the last section of it around what has been going on in the meantime about the things that we actually know can help people. So Nolan was talking about this difficulty with psychiatry looking like medical care, but actually it's also true that in psychiatry we have some treatments that work. Okay, and thinking about the general treatments of our conditions, of our common conditions that actually have effects, psychotherapy, psychopharmacology, relational therapies, the treatment of overt psychiatric conditions of parents. These are things that are in our reach, but are not reaching people. So in childhood, for example, of all children who have serious, clinical depressive syndromes, most don't ever get any treatment in childhood. The ones who do, it's 5 to 7 year delays in their treatment. And suicide is one of the leading causes of death of all children. But they're not getting access to the treatments that we have. This is another example of not getting access to the treatments that we have in autism. So we think of autism as an inherited condition or a genetically influenced condition. But I want to tell you a little difference about a disparity in autism, which is that if you're white with autism in the United States, the likelihood that you also have intellectual disability, which generally renders you having very great obstacles to communication and to learning and so forth, 20% of Caucasian children with autism end up with intellectual disability. But if you're a black child with autism in the US, it's 50%. And this has been demonstrated over and over and over again through epidemiologic studies where all the old excuses about why that might be, maybe ascertainment bias, have been eliminated. And we have learned that the reason for those disparities, those huge disparities, this condition affects 2% of children in the population. And this disparity, do the math of how many people it would affect if you change from a 20% to a 50% comorbidity with intellectual disability. And it's traceable to delays in diagnosis, delays in developmental therapy, and a differential in early education in order to promote adaptive functioning in these children. And we showed in a project that kind of muddled through the pandemic recently that if you level the playing field, diagnose black children on time, give them the developmental therapies that are the standard of our field, you see instead of an erosion in their function, a gain in their function, and their preservation of the same kinds of statistics for IQ as you do for other kids. And so we have to deliver that. Another example of forces at work in the social development of children, this is for antisocial behavior, that at every level of inherited liability, another boost to the likelihood that an antisocial trajectory of behavior is going to develop in a child comes from preventable forms of child abuse and neglect. Child abuse and neglect affects 1 in 8 children in the U.S. And why do I say that it's preventable? Because it is preventable. Because we can predict, in many cases, who is at risk for lapses in supervision and difficulties in family environments and so forth, and families that are going to struggle with the safekeeping of children. But if you identify those at risk, and so this was a 10-year longitudinal follow-up of 400 children referred from the St. Louis County Family Courts for infants and toddlers after a first instance of child abuse or neglect. Typically, in care as usual, those children half of them will go home, and when they go home, 40% of the time, they will end up back in the child welfare system. And long story short, that when you deliver parenting education as an evidence-based practice, treat parental mental health conditions, support those families, do parent-child interactional therapies that we know have effects, and help the courts and so forth support those families' reunification, then the rate for child abuse recidivism drops from 40% into the 5 to 6% range. And this was published in the journal Pediatrics not too long ago. So we have these major gaps in the mental health system, and I've alluded to these different places where we have opportunity to offset enduring mental health conditions of childhood. You know, in our prevention programs, in primary care, where early depression and early psychiatric conditions are first recognized, in schools, in specialty mental health programs, but there's not enough care to go around. And what's happening, not only in our country, but across the world, someone mentioned Patrick McGorry, this is one of the studies, that around the world, we're losing the battle. Children's mental health is getting worse. Okay, these are plots across the different, decades from 2004 to 2021 in different national surveys in the US, Denmark, England, Australia. And in every case, things are getting worse for kids. So how then can we make mental health for children and put it on a par, just as Nolan was alluding to, how can we make it look like medical care? And what we can do is fulfill what is federal law, which is mental health parity. That mental health care needs to be supported, funded, and elaborated at the same level as any other medical condition with the same level or comparable level of risk. In the United States, one of the smoking guns, I'll call it, the signatures that parity doesn't exist, even though those federal parity laws have been on the books since 2008. These are plots of what's happened since then in the proportion of all outpatient mental health care that is delivered by self-pay. So for medical conditions, only about 1 to 2% of all outpatient medical care is you have to pay for it out of pocket. In psychiatry, 30%. Okay? Why? You wouldn't pay voluntarily for, having a broken arm or needing care for an asthma episode. No, it's because you can't get it otherwise. And the issue is that we have not fulfilled federal law. So what if we could fulfill federal law? And I'll just skip through these last couple of slides. But the idea is, what would happen if we actually simulated the delivery of the evidence base of our field? And so that's what we're doing in Georgia, and with the goal of population level reductions in the biggest adverse outcomes of child mental health conditions: death, hospital encounters for crisis, foster care placement, school dropout, teen pregnancy, substance use impairment, delinquency, and crime. And we've set the whole thing up by using essentially what was created at Children's Healthcare of Atlanta as an endowment. And the endowment was large enough to cover, we're at about 5,000 kids per year that we can bring into a model of care where, on time, you get the evidence base of the field as a child. And we are studying what is the impact of that versus care as usual, what is the true cost, And in the long run, can we influence the payment system for making sure that the true cost is paid so that clinicians can be attracted into the field to deliver these services, that all of this work has already shown that we have things that actually can help. And this is the science of implementing what we already know. So I want to thank the Brain and Behavioral Research Foundation, and I want to really acknowledge and thank my collaborators over the years. My first mentors at Washington U were Lee Robbins and Richard Todd and his wife Karen O'Malley, who have been great supporters to our program. And Richard is passed, but what was very, very close to me and somebody who drove a lot of the early, inspiration for a lot of this work. And I've listed also some of the many collaborators in the scientific program. Washington University was very good to us. From the leadership standpoint, Chuck Zaromsky was one of the great chairs of psychiatry and is still at Washington U. I certainly want to thank my family, who is represented in that picture, my wife and our children, for all the support over the years. And next to me in that photo is my daughter, who is a postdoc at Washington University in St. Louis, mentored by Deanna Barch, and a young investigator. And the others at Emory, Children's Healthcare of Atlanta, and Dan Geschman at UCLA, who have been really major figures in advancing this line of work. Thank you.
Is there a question or two? One, here we go. I'll ask one. Oh, here we go.
Thank you so much for that presentation. It was so insightful. So my question is, as a mental health counselor, how can this research be translated into therapeutic interventions that counselors and psychologists can use?
Well, I think that the interventions that psychologists and social workers and therapists use, these fall into the category of things that we already know work. Cognitive behavioral therapy, dialectical behavioral therapy, the parent-child interactional therapy. We know that these interventions work. And what you're alluding to is the fact that, well, if nobody's paying for them and there aren't enough people to deliver them, then children who could benefit from them are not going to get them. So the idea, again, within this new model of care, which is is somewhat of an experiment at Children's Healthcare of Atlanta, is to say, let's bring enough monetary resources to cover a scaled, a large population. And so all of those services are part of the service repertoire. When a child comes into this model of care, and this is 70% governmentally insured children, these are children in the Medicaid program. And when they come into this model of care, they're coming into a model of care that they did not have access to before, and they have a physician if they need it, they have a psychologist if they need it, they have a social worker if they need it, and the care is organized around them, not around a service bureaucracy, but around them and what they need. And so the lead clinician elaborates the care plan, every bit of the evidence-based treatment that would help that child, and then we assemble that care either by doing it ourselves or working with our partners in the community. And when there's really not adequate levels of that care, if we have to build it within the program, a new program, and use subsidies to cover it, we document that. And so part of the program, even as it is modeling what this should look like, is documenting essentially when federal law is being violated. And so at this point, we have documented essentially 1,000 auditable situations where a child should have had an element of evidence-based mental health care that they couldn't get. And we're going to use that evidence as well to try to really work with the system, the payers, that we have to do better, and it is part of federal law for there to be adequate coverage of those services that you are providing. So, yeah.
Do you anticipate that once you get this whole program going and the children have much better care than they had before, it will be a financial advantage in the long run?
Well, let's hope, because I think the best chance that these investments get replicated everywhere else is to show cost savings. But, I think I think some of them will show cost savings, and maybe most of them and maybe all of them will show dramatic cost savings. But even if they don't, when we can make a case for a dramatic improvement in the quality of life, I mean, all medical care costs something. And psychiatric care, the magnitude of impact on quality of life is very comparable for some of our evidence-based treatments to many, what's available for medical conditions. So I think the other card that we have to play is not only to show, that it improves in terms of cost savings, but also that, again, we have decided in this country that mental health parity is the law of the land. It's federal law. That we shouldn't have people dying of psychiatric conditions that are of equal, morbidity and mortality just because we decided not to have adequate treatment for those who could benefit from it. So there has to be an equity, proposition as part of this, and really we have to stand firm on that. Yep.
I live in